Hello, everyone. We will wait a couple of more minutes for the participants to join. Can you hear me well, Hanan? Yes? All right, that's great. So welcome to the Nano in Medicine and Health seminar series. This is a joint effort between the Nanomedicine Lab at the University of Manchester and the ICN2 in Barcelona. It's a great pleasure to have as a keynote speaker Professor Avi Schroeder with us today. Before that, we will have Dr. Hanan Abumanhal to open up the seminar with a short talk. Hanan is a postdoc here with us at the University of Manchester, but she did her PhD under the supervision of Avi. And so today she will present, she will give a brief overview of her PhD work at Technion. We will have time for some questions after her talk. If you have any questions, please either write them in the chat or in the QA chat that you can all see in your Zoom. So Hanan, when you're ready, please share your presentation.
Good afternoon. Can you see the screen?
Yes.
Okay. So good afternoon, everyone. I'm really happy to open this seminar with a short talk about my PhD research, which was done under the supervision of Professor Avi in the Technion Institute of Technology before moving to the University of Manchester for my postdoc research in the Nanomedicine Lab. My PhD study focused on using nanotechnology for targeting the tumor microenvironment. And in the last years, there is an increase in the interest of using nanoparticles for targeting different components of the tumor tissue, and the need for combined treatment that target and treat the cancer cells as well as other components of the tumor tissue is really clear now in order to enhance cancer treatment, such as targeting the ACM, targeting cancer metabolism or metabolic reprogramming, and remodeling the immune function, and remodeling the blood vessels vasculature. And in my PhD research, I focused on targeting one of the main metabolic characteristics of the tumor tissue, which is called the Burberry Effect. You can see here that in cancer cells, regardless of the oxygen amount, the main energy production is by the conversion of glucose to lactate through the aerobic glycolysis. And since cancer cells consume large amount of glucose to feed their energy needs for proliferation, a high amount of lactic acid is produced inside the cancer cells. And in order to keep their intracellular pH, cancer cells secrete the lactic acid to the extracellular compartment, which causes to a decrease in the extracellular pH to around 6.5 to 6.9. And this extracellular acidity is involved in many signal cascade pathways that lead at the end to more aggressive, metastatic, and drug-resistant tumor. In my study, I focused on the effect of the acidic tumor microenvironment on the activity and cellular uptake of weak base drugs such as doxorubicin. And you can see here that in the acidic tumor environment where we have high proton concentration, the drug become more charged and its cellular uptake is reduced. And what we thought that by the delivery of alkaline buffers such as bicarbonate using nanoparticles, we could modify the extracellular acidity and increase the uncharged form of the drug, which can increase or enhance its cellular uptake and thus its activity. So in the first step, bicarbonate liposomes were prepared, and they were composed of HSPC, DSPE, PEG, and cholesterol, and they were around 100 nanometer. And in order to characterize the intraliposomal pH, pyranine, which is a fluorescence pH sensitive indicator, was used, and liposomes encapsulating pyranine with and without bicarbonate were prepared. And we could follow up the intraliposomal pH based on pyranine fluorescence intensity, as you can see here in the pH scale, according or based on pyranine intensity. This is the obtained values up to 1 week after liposomes preparation, with a difference of two pH units between empty and bicarbonate liposomes. Then we wanted to examine the effect of combining bicarbonate liposomes on doxorubicin activity, on doxorubicin cellular uptake, and moving to in vivo models. We wanted to examine their direct effect on the tumor acidity and the potential of using them as an adjuvant treatment. So working with 41 triple negative breast cancer cells, we wanted to examine if we could have enhanced effect once we combined bicarbonate liposomes with doxorubicin and how this combination could enhance the drug activity. We worked with two media pH, 6.5 that represent the acidic tumor microenvironment and 7.4 that represent the physiological one. And we can see here that combination of doxorubicin with free and with liposomal bicarbonate resulted in decreased cell viability, which means increased drug activity. And with the increase of the media pH, further decrease in the cell viability was obtained, which means enhanced drug activity. And this indicates that this drug works better in more alkaline environments. Then I wanted to validate if the obtained enhanced or increased activity was due to an increase in the drug cellular uptake. And since DOX is a fluorescence molecule, we could follow up its cellular uptake based on fluorescence measurements. And you can see here in these images, the increase in the red fluorescence signal in the case of the combined treatment once we compare the signal with treatment with the drug alone. And for quantitative data, flow cytometry analysis was done, and you can see here the blue histogram that represent the combined treatment. This right shift in this histogram indicates to increased fluorescence intensity of the drug inside these cells in the case of the combined treatment, which indicates to enhance cellular uptake of the drug. Moving to in vivo studies, I focused on the biodistribution of bicarbonate liposomes in the tumor tissue. And we wanted to examine the direct effect of these liposomes on the intratumoral pH. And by efficacy experiment, we wanted to examine if we could have adjuvant or enhanced therapeutic outcome once bicarbonate liposomes combined with doxorubicin. Since our biological target is the extracellular compartment, we were interested to examine the distribution of these particles in the different compartments of the tumor tissue, specifically the cellular compartment and the extracellular compartment. And using gadolinium-loaded liposomes, we could quantify the distribution of the particles in the different compartments in the tumor tissue. 24 hours after IV injection of the liposomes, we found that 3.7% of the injected dose were accumulated on the tumor tissue. And if we look inside the tumor tissue itself, the majority of the liposomes were located in the extracellular compartment, and only 7% were found in the cellular compartment. In addition, evaluation of the intratumoral acidity was addressed, and direct pH measurements of the tumor pH were done using pH microelectrode, and the intratumoral pH was measured 24 hours after IV injection of bicarbonate liposomes. And you can see here that compared to the values obtained for the untreated group, a shift in the values toward more physiological values were obtained in the bicarbonate treated group mice, which indicates that the potential of these liposomes to modify the tumor pH to toward more alkaline values. In addition, ultrasound scanning of the tumor tissue was conducted using a contrast mode, and compared to the injection of empty liposomes, we can see that a contrast change was observed during the injection of bicarbonate liposomes, and this change in the contrast could indicate to the interaction between bicarbonate and protons generating carbon dioxide gas, which could be detected as contrast change by the system. And here on the right, you can see the contrast mean power ratio over time after the injection of the liposomes. And in this time point, we can see the increase in the contrast. In addition, I evaluated the potential of using bicarbonate liposomes as adjuvant treatment, and tumors were induced in the mammary fat bed after the injection of 41 triple negative breast cancer cells. And these different treatment groups were examined, and we followed up the tumor size throughout the experiment. And we found that smaller tumors were obtained once free dox and liposomal dox were combined with liposomal bicarbonate, and the same data was obtained on the tumor weight results. And actually these results indicate that we could have enhanced therapeutic outcome in the case of combined treatment of liposomal bicarbonate with doxorubicin. And to summarize, I could say that bicarbonate liposomes were engineered, characterized, and used as an adjuvant treatment. And we see that combined treatment using bicarbonate liposomes and doxorubicin could enhance the therapeutic outcome in 41 triple negative breast cancer cells by enhancing the cellular uptake of the drug. And this study actually demonstrates that targeting metabolic adjuvants with nanoparticles to the tumor microenvironment can enhance the anti-cancer anti-cancer activity of drugs and improve cancer treatment. At the end, I would like to thank the Schroeder's lab in the Technion for a great PhD experience that I have with them. And thanks, Avi, for helping, supporting, and encouraging me all the time. And I would like to thank the Nanomedicine Lab for welcoming me during the last few months and for inviting you, Avi, for this seminar. And thank you all for listening.
Thanks a lot, Hanan. If you have any questions, can you please write them in the chat? Any questions from the audience? If not, I have a question, Hanan. If you go, well, you don't need necessarily to share the presentation, but in your last slide, you mentioned that you can combine adjuvant liposomes with doxorubicin containing encapsulated liposomes. So in a clinical scenario, would you inject both formulations at the same time? How would it work?
Actually, in this experiment, we injected the bicarbonate liposomes 24 hours after the injection of doxorubicin. It was a really challenging point in the study to choose what is the best time to use this adjuvant treatment. So we thought that maybe pre-treatment for the tumor microenvironment could prepare the pH or the tumor acidity, and then once we apply doxorubicin, the effect of bicarbonate would happen. So I think maybe it's kind of pre-treatment before having giving the treatment of doxorubicin will have a better effect. And this is the reason why we thought that we tried this treatment in vivo, kind of pre-treatment, preparing the tumor acidity, and then once we give the doxorubicin, we already have the modification of the tumor microenvironment.
And would you administer doxorubicin or liposomal doxorubicin? Actually,
we tried both, and the effect with the combination with the free doxorubicin was higher. And I think it's because it's free in the tumor microenvironment, and the effect on its charge is more, rather than once we give the liposomal dox, it should be released, and then we tried both, and the effect with the free was higher.
So we have a question as well in the chat. Is the targeting active or passive?
It was passive targeting. We don't modify the surface of the tumor of the nanoparticle. The normal body pH is slightly alkaline, while dox don't produce. So actually, doxorubicin is a chemotherapy, and we all know that it's already approved and it have side effects. And this is one of the reasons why the liposomal the liposomal doxorubicin aimed to do or to decrease the side effect of doxorubicin. So it has side effect, and the liposomal form of dox reduce these side effects, especially the cardiotoxicity of the drug.
Great, thank you very much, Hanan. If we don't have any other questions in chat, so I would like to thank one more time Hanan for her very nice talk. It's great to have you here in Manchester now. Thanks, Avi, for training Hanan. And so now I would like to welcome Professor Avi Schroeder. It's a great pleasure to have you with us. He's an associate professor of chemical engineering at Technion, and he leads the laboratory of targeted drug delivery and personalized medicine technology. He conducted his postdoctoral studies at MIT, and he did a joint PhD between Hebrew and Ben Gurion universities. Avi has received more than 30 national and international awards. He has published more than 50 research papers and 19 patents, has co-founded multiple startup companies based on these discoveries. He's a member of the Israel Young National Academy of Science, the Israel National Council of Civilian Research and Development, and he's a president of Israel Institute of Chemical Engineers. He's world famous for the development of cancer nanotherapeutics. And today he will give us a talk about barcoded nanoparticles for precision cancer medicine, the effect of tumor type and patient sex on anti-cancer efficacy. Avi, thanks a lot. The floor is yours when you can share your screen.
Yeah, so thank you, Marilyn, for this very kind introduction. I'm very excited being here, and Hanan is very lucky to be working with you. And this entire consortium, I think, is a fantastic consortium scientifically. So I can only wish that we have more interactions with people from the consortium. So yeah, one second, I'll share my screen, but I see something here stuck. Okay, good. So just a bit of the geography where I'm speaking to you from. So we're located in Israel, not very far away from people here on this call today, and specifically from the city of Haifa. So this is a picture from the city of Haifa. These are the Baha'i Gardens overlooking the Mediterranean Sea. So we also share a sea with most of the people on this call. And so the Technion is just a couple minutes away by driving from the Baha'i Gardens. But for people who haven't been yet to Israel, in the south of the country, we have Eilat, which is great for people that like scuba diving and seeing the coral reef. Jerusalem, of course, in the heart of Israel, and Tel Aviv, the city, I think that's awake 24/7. So with great restaurants and a lot of culture. So in addition to science, for those who want to come and visit, we'll be very, very happy to host you here in Israel. And looking forward to see you all. And the borders actually are open now. So please come and visit us. What brought me into the field of nanotechnology, I think many people here, you know, when we started the field of nanomedicine, had a lot of promise, but today it actually also, a lot of it has been realized. And the promise I saw is when I was an undergraduate student, I read this paper that was published by Harrington and coworkers, and they were actually looking at nanoparticles and how they distribute inside the body of patients. And I'm sure many people here have seen this study, looking actually at different cancer patients, a tumor at the base of the tongue, a patient with breast cancer and metastasis in the local lymph node, and a patient with lung cancer and metastasis in the spine and the bone marrow. And even though each one of these patients has a different type of tumor, they were all injected 100 nanometer liposomes, and inside the liposome was a contrast agent. And these liposomes actually accumulate preferentially at the site of the tumors and metastasis due to the enhanced permeability and retention effect, or to enhance permeability of the tissue. So I think for us working today in the field, we know that not only in cancer this exists, this also happens in infection and inflammation. However, not every cancer patient actually presents this type of biology, meaning that for some patients, maybe nanotechnology won't be the best way of treating them, or that we may have to add another mode of targeting. If people asked previously about targeting, passive and active targeting, So this is the passive targeting, and for active targeting, you may want to add an additional molecular components in order to improve the efficacy. But the systems that we started working on are lipid-based systems. This is a liposome in front of you. And when we look at most of the treatments that reach the clinic today, most of them are around 100 nanometers in diameter. The liposome has the drug would be loaded either in the inner aqueous core, the lipid bilayer, and then you can add targeting moieties to the surface or add molecules in order to increase circulation time, such as polyethylene glycol. I think a lot of the engineering of these systems actually goes into the lipid bilayer, which is there in order to retain the particle so that when it's in the blood, the medicine doesn't release, but once it reaches the target site, it actually releases the medicine in an effective dose. So there's a lot of engineering, and this actually varies from one drug delivery system to another. The size, even though lipid nanoparticles really changed a lot, the size it depends on the type of disease, but for many of the injectables, we're talking about 100 nanometers. That's what you see in many studies and in the clinic. And just to put into context, there are many drugs that are out there already being used. Doxil was the first, was actually invented by my PhD advisor, Professor Chezi Berenholtz and Alberto Gabizon in the Hebrew University. And this is a one drug nanoparticle, so 100 nanometer liposome with doxorubicin inside it. And it's still being used for treating nearly 600,000 ovarian and breast cancer patients around the world every year. So that's still big numbers if we're talking about a drug that was actually approved in 1994, 1995. But since then, the field has really evolved a lot. Vyxeos is just an example of a lipid nanoparticle, liposome with two medicines inside at a ratio of 1:5. So now having two drugs inside the nanoparticle. And it's been shown that also at the intracellular level, having two medications usually gives a better therapeutic outcome, but they don't have to be at a ratio of 1:1. And this is what makes it actually a technology, and not just both drugs reaching that site. And while these two drugs, Doxil and Vyxeos, are injected intravenously, Arikocite is actually given inhaled. And these particles are actually larger. They're 300 nanometers in diameter. And that actually has been shown to reach very distant sites in the lung. And of course, when COVID outbroke, the amikacin, which is an antibiotic inside these liposome, was replaced by a different medication. So this is a real platform. So this is an antiviral medication that actually was approved or was tested when COVID didn't have any vaccines that are out there. But I think one of the big breakthroughs in the field was actually around December 2018. So we're talking very recently, the approval of Onpattro. Onpattro is a lipid nanoparticle. So there is no inner aqueous core. Now it's all one lipid particle. The size is about 100 nanometers in diameter, but instead of having a small molecule drug, this actually contains a siRNA, short interference RNA, in order to inhibit the production of proteins inside of cells. And more specifically, Onpattro, which was developed by Alnylam, a company in Boston, is actually used for treating a disease called HATTR. And what it is the malformation of proteins inside the liver. These proteins aggregate into myeloid, which then are trafficked to amyloid, which then traffic to the nervous system, inducing terrible side effects and eventually even death. So this disease had no cure until these nanoparticles were developed. And when the FDA actually stopped the clinical trial after 18 months, they said, listen, we haven't seen such significant data in 15 years of clinical trials. And they called this clinical result alligator clause, where the patients that were responding, you can notice them here, and the patients that didn't respond, they received just a control, they were here. So and then the FDA actually said, all patients should be getting the treatment and are improving in their sight. So nanotechnology here really is an enabling factor. It's not only for reducing side effects and improving the therapeutic efficacy. If you'd inject the RNA without a carrier, without the nanoparticle, it just wouldn't enter the cells and wouldn't be as efficacious. So since then, really, I mean, the big breakthrough was when COVID hit us all. So taking very similar particles to those that were used for treating HATTR, the liver, and replacing the siRNA with messenger RNA. This is a sketch just of the Moderna particle, and using this for treating COVID by expressing the spike protein inside in patients. And actually, the particles are pretty similar. The Moderna and the Pfizer particles. The RNA is slightly different. And this is one of the vaccines that we imaged under the cryo-TEM. You can actually see the particles are 100 nanometers in diameter. You can't see the RNA inside. The particles aren't very, very stable. I can tell you that after thawing them, the particles start growing in size. And I think that's just because there was a very short time to bring these to market, and there wasn't time to perfect them. And I'm sure the next generation of vaccines will be much more stable, as we'll see in the future. But again, a very spherical, nice particle with the RNA loaded into the nanoparticle. And that's, I think, where we are. So if we were talking, 4 years ago or 3 years ago, we'd say that only millions of people have received nanotechnology. Today, billions of people have received nanotechnology medications. And I think this just shows how impactful our field really has, and that we're just touching the iceberg. And the COVID case really showed how efficient these systems can actually be. And just from a bit of chemistry, because I know many people here are interested about the chemistry. So if we look at what the field actually has evolved, so this is the formulation of Doxil, the lipid formulation, and it contains 3 lipids. The first, HSPC, is the main building block. The second is cholesterol. So if the HSPC alone is enough to create liposomes, actually these liposomes are not very stable. I always think of them as building bricks of a house without cement, and that's where the cholesterol actually plays a role, being the cement inside between the lipids and sealing the lipid bilayer. This alone creates these 2 components alone, cholesterol and HSPC, would create very stable liposomes, but they'd be removed by the immune system within less than 30 minutes after injecting them intravenously. And that's where the third technological component comes in, and that's the pegylation, the lipid, the PEG lipid, so the PEG head extending out of the surface of the nanoparticle, binding water molecules through hydrogen bonding, and actually extending the circulation time up to 24, 48 hours, in some cases even longer. So it depends really on the different situations. So 3 different layers of technology: stability, and also being able to actually have that long circulation. And if we look at the lipid composition of the COVID vaccines, they haven't changed much. So the HSPC was replaced by a cleaner version, DSPC. Cholesterol is there too. The pegylated lipid is there too. Slight difference. The lipid tail chain is shorter in the PEG. And the reason is to allow the PEG molecules to fall off earlier from the particles. And then there's an ionizable lipid that actually allows connecting or conjugating to the RNA. So this amine group right here in the red rectangle, this amine group here of this ionizable lipid, which is a totally new synthesized lipid, it connects or binds through electrostatic, binds to the RNA, the negatively charged RNA, actually to stabilize the particle. And it's called ionizable because the amine actually isn't always positively charged. You need to charge it using the slightly acidic pH when you form the particle. So that's as a field. And I think showing that, or at least what it emphasized to me, is that the lipids actually play a very important role when you come to design new drug delivery systems. And there's a lot of importance to actually choose the lipids in a way that will serve your therapeutic purpose and also serve the drug. Just an example of that is a study we conducted several years ago. And here we were designing liposomes for treating a disease called osteoarthritis. This is a degradation of cartilage in the joints. And here we had no drug at all, only the particles, only the liposomes, which were injected directly into the joints, into the knees of patients with osteoarthritis. The thought behind it was that the liposomes will actually act as a biomaterial, a lubricant that will reduce friction and wear inside the joints of the patients and thereby reduce the pain. And what we did is we designed a very soft lipid bilayer, not too soft so that it falls apart. So I think of it always as a mattress in a good hotel, that it's soft, but not too soft, right? And so it can carry the load of the body. It delaminates, these liposomes delaminate on the surface of the cartilage and create this barrier so that the two opposing cartilage surfaces actually can slide one against the other with very, very low friction, and that ends up with less pain. And in fact, this is a clinical trial that we ran with these liposomes, and we saw that the patients, so the blue bars are those that were treated with our liposomes, that patients after 30 days and the same also after 90 days actually were able to regain their function. So the test was, can they do their daily activities, get in and out of a chair, climb up and down stairs, go for a walk? And the patients really showed a great improvement in that. A very nice thing that happened is on the small left-hand side of your screen on the bottom, there's another graph, which was actually looking at the amount of pain medication these patients were consuming throughout the period of the trial. And what we saw is that we actually had here a positive side effect. The side effect was that the patients which were receiving our liposomal treatment into the joint actually were consuming less pain medicine. And of course, for a chronic illness such as osteoarthritis, you want to reduce the total amount of pain medicine that a patient will be receiving throughout the period of the disease. So we actually had a good side effect, and not which was happy that accompanied the treatment. I'd like to go back to the example of the 3 patients with cancer, and a question that we asked ourselves a couple of years ago was, can we use the nanoparticles' ability to accumulate at the site of the tumor, not only to deliver medication, but also to try and prescribe the medicine in a better manner? Meaning, could the nanoparticle be a sensor that will give us a readout about which medicine will be best for each cancer patient? And just to emphasize the need for this type of technology is a conference I attended just some time ago. And this is a totally clinical conference, only medical doctors and myself, the PhD, giving the scientific talk. And then they asked the MDs, they asked them clinical questions throughout the trial, throughout the conference, and they're all experts in breast cancer. So they have a female patient, she's under the age of 50, she has node-negative breast cancer, ER positive, HER2 negative, and a recurrence score between 21 and 25. And they asked the physicians, what should she get? Chemotherapy and Erbitox, OFS, which is radical surgery and Erbitox, chemotherapy, OFS, and Erbitox, or only Erbitox alone? And I, being an engineer, I was sure, one of these answers will get, 80% of the results or the response. And then the physicians chip in, and I see this, and I would say that if our lives wouldn't depend on it, this was almost be funny, because if you go to doctor number 1, you'll get treatment number 1, and almost divide it almost evenly between the different answers. Or if you go to doctor number 2, you get treatment number 2. And then they actually showed this response, and they asked the same question in a very large conference. This conference had 350 physicians. When they asked the same question in a conference with 4,000 breast cancer physicians, they actually responded totally different than the conference I was at. So there, 42% responded to 1, 25 to 2, and thereon, meaning that actually choosing the right treatment methodology for each patient is a very hard task. And we thought that maybe nanotechnology could help here. And for people that are wondering, what's with genetics? So genetics really help a lot. They improve medicine immensely. We all know that. However, also the genetics don't give you a full picture. For example, here, this is a real picture from a genetic scoring for a patient. In this case, it's glioblastoma. And the genetic test actually offers 6 different medications. You can see right here. Now, that's totally impossible to give 6 therapeutic doses of medication at the same time, simultaneously. And in this case, actually, it's very sad. The patient received one of the 6 and she didn't respond. Then by the time they reached the 3rd one, she started responding, but it was just too late. So how can we save that very precious time for the patient? And what we did is we asked ourselves, could our nanoparticles actually act as small sensors that will give us a readout about which medicine works and which medicine doesn't work inside the patient's body? And the way we went about it is we took liposomes, all 100 nanometers in diameter. And what we did is we loaded each liposome with a different medication. In fact, the dose was so low per liposome is that we needed to add a DNA barcode to each one of these nanoparticles in order to know which medicine we have inside each one of these nanoparticles. So now we have a cocktail of nanoparticles, each one with a different medication inside it, in a DNA barcode that denotes which medicine is inside the nanoparticle. And we can inject these nanoparticles intravenously. I'll be showing now this data will be in mice. The nanoparticles injected intravenously, they circulate in the blood, they're taken up by the breast cancer tumor through the leaky blood vessels. And then this takes about 24 hours. We wait another 24 hours for the drugs to work or not work inside the tumor. And then we take a small biopsy from the tumor tissue, and we break it up into live cells and dead cells that are coming out of the tumor tissue. The live cells contained barcodes of ineffective medications, and the dead cells contained barcodes of effective medications. So we actually have a system now here for predicting the potency of drugs in a rather short period of time. So 24 hours after the injection, the particles, we see them accumulate in the tumor. We wait another 24 hours for the drugs to work, and then we can actually take the biopsy at that point. So, and the analysis, of course, takes maybe another 24 hours. So we're talking about 70 to 96 hours till you get the analysis back with the data that can recommend which drug to give. So what does it look like after injecting the particles intravenously? We see them inside the tumor. You can see here a cut of the tumor and the accumulation of the nanoparticles in pink here inside the tumor cut, or the barcodes actually inside a triple negative breast cancer cell. They're labeled green, and you can see them actually inside the triple negative breast cancer cell. Now, the assay is a single cell assay, as we have live cells and dead cells coming out of the tumor, and we need to look at each one separately. And we get this panel of live cells and which barcodes they have inside them. This is the lower panel, and the dead cells and the barcodes they have inside. For example, and this is just an example, we usually look about 3 million cells from the live and the dead. And you can notice that we have the greater abundance of the blue barcodes in the panel of the dead cells compared to the blue barcodes in the live cell, in the panel of the live cell. This blue barcode actually corresponds to a drug called gemcitabine, which we found throughout the study that was in greater abundance in the dead cells compared to the live cells. So we can actually assume that this drug will actually be more potent. But if we take it actually down into the math, we can measure per cell and then divide how many dead cells have a barcode of gemcitabine versus how many live cells have that barcode. And if I'll start from a different drug, from cisplatin, when we started with looking at the cisplatin barcodes, for each 5 dead cells coming out of the tumor with a cisplatin barcode, we had 1 live cell. So this is a ratio of 5 to 1. So pretty good, 5 dead to 1 live, that's good. But then when we went on to gemcitabine, we saw that for each 6,500 dead cells coming out of this specific tumor with a gemcitabine barcode, we had only 1 live cell. So the barcoding system actually allows you to strategize which medicine to give, because you'll rank here gemcitabine first, cisplatin second, and doxorubicin, which had in this case almost a ratio of 1 to 1. This is a triple negative breast cancer, which sometimes does not respond to dox very well. So we saw that the doxorubicin had a ratio to 1 to 1, so that would be ranked third. And we created this potency chart that ranks the different medications. And then we went and we tested, is our ranking, does it really prove itself also when we come to give a therapeutic dose to the mice? And what we saw is that the tumors were smaller when we treated according to the prediction. The mice lived longer. And more than that, when we looked inside the tumor itself, so we ran histology on these tumors, we took a Ki67 proliferation staining, and we saw that the tumors that were treated according to the prediction were actually in regression, while the tumors that were treated against the prediction with a drug that proved in this case to be less effective were in progression. So not only at the macro scale are the tumors smaller, but also at the micro scale, the tumors actually are responding better to the medication. And but then we wanted to take it one step forward, and we asked ourselves, we know that tumors are about 50% cancer cells, 50% stromal cells, and we asked ourselves, how are different cells inside the tumor microenvironment responding? And more specifically, for example, T cells inside a tumor, sometimes we want them there, we don't want them to die. So are we treating with a drug that will kill the T cells, or maybe we want to give a drug that will actually be more potent against the cancer stem-like cells? So we asked ourselves, how different cells inside the tumor microenvironment are responding. And what we found is actually that different cells inside the tumor microenvironment respond to different medications. And for example, if we take the T cells on the top left-hand corner, this is a slightly busy slide, the T cells were responding not only to the cancer medications, but also to dexamethasone. Now, dexamethasone is sometimes given to cancer patients to treat nausea. Now, if you're giving anti-nausea drug, which is important, but it's depleting the T cells inside the tumor and you're giving immunotherapy at the same time, you may actually be losing the effect of the immunotherapy because you don't have the soldiers inside the tumor, the T cells, to fight the cancer cells. So these are things when you come to strategize, and they're on for different types of cells inside. So we asked, that's the primary tumor where we know we can actually choose different medications based on the types of cells we want to deplete inside the tumor tissue. But what's about metastasis versus the primary tumor? Does the metastatic site respond to different medications compared to the primary tumor? And what we saw, interestingly, using this spontaneous triple-negative breast cancer model, where you inject the cells to the mammary fat pad, and then after about 3 to 4 weeks, you start seeing metastasis throughout the body of the mice. Very similar biodistribution to that of human or clinical triple-negative breast cancer metastasis. You find them in the brain, in the liver, in the lungs, in the bone marrow. And we asked, how are different sites of metastasis responding to medication? And what we saw is that different metastatic sites respond to different medications. For example, brain metastasis were responding to selenomycin, which we found actually was a drug that worked previously in the cancer stem-like cells. However, in the primary tumor, that was responding to gemcitabine. What made me very, worried or concerned in this study is almost sad, I would say, is looking at the graph you see on the right-hand corner. And what we looked at is the number of barcodes we had per dead cell inside the primary tumor and in the metastasis. And for example, if you have one barcode in a dead cell inside the primary tumor, in the lungs, for example, you need 4 barcodes to kill that metastatic cell in the lung, meaning that the cell in the lung, the metastatic cell in the lung, may be more resistant to treatment compared to the cell in the primary tumor. And this is also seen many times clinically, that while the primary tumor may respond to one medication, the metastasis may need more of that medicine. And I think this highlights the need for drug delivery systems, targeted drug delivery systems that can reach also sites of metastasis in order to treat cancer once it spreads to other regions, which we know that's when many clinical options or opportunities are a lot less available. So resecting, for example, a primary tumor is possible, but resecting many metastases usually is not something that's feasible. So I just want to wrap up this concept with a slide animation that demonstrates the barcoded nanoparticles being injected intravenously. These particles enter the tumor through the leaky blood vessels, and then the nanoparticles actually distribute between the different cancer cells. And the nanoparticle injects also the barcode and also the medication. And then based on the activity, you can actually get a feeling of a readout about which medicine works and which medicine actually is less effective inside in the patient. I'd like to move on. And Marilyn, how much time do I have?
You still have 10 to 15 minutes, Avi.
Okay, very good. Thank you. That's all I need. So when we were working on breast cancer, many people walked up to me, came up and said, Avi, breast cancer, we know that nanoparticles are taken up well. What's with low penetration tumors? More specifically, what's with tumors such as pancreatic cancer that we know pancreatic cancer is a hard cancer to treat because of the excess collagen that exists in the extracellular matrix of the pancreatic tumor. This collagen is a barrier for the penetration of drugs and also of nanoparticles. And in fact, beautiful studies that were conducted by Terry Allen and other people in Canada actually show that the collagen itself acts almost as a glue that deactivates many medications after reaching the tumor site. And we asked ourselves, could we first maybe reduce the amount of collagen inside the tumor and then follow up with a treatment? So the collagen, which exists inside the tumor, is a barrier, and can we actually reduce its content? And you can see in front of you two cuts. On the right-hand side, in blue, you can notice all the collagen inside a pancreatic tumor. This is a Mason tree chrome staining. And this collagen matrix actually is protecting the cancer cells and actually making it very hard to treat the tumor in an effective manner. Look at the amount of blue compared to the healthy tissue on the left-hand side. So the concept was, we have a nanoparticle that can cut a hole through that collagen and make the drug create tunnels for the drug to penetrate into the pancreatic tumor. And the perfect scalpel for treating collagen would be collagenase. Collagenase is an enzyme that is naturally against collagen. And what we did is we loaded the collagenase into the liposomes, and then we tested its ability to degrade the collagen bundles. And we saw that the collagenase, of course, is active against the collagen fibrils. And more than that, when we tested this in pancreatic tumors, you can see this is a slightly busy slide. So the two panels D and E. D is a pancreatic tumor after being decellularized. You can notice the dense collagen matrix. E is already a pancreatic tumor after being treated with liposomes and collagenase. And you can actually notice that the amount of collagen is significantly depleted, now allowing particles to penetrate. So a second dose of particles with a drug now to penetrate into the tumor. So the concept would be to give two treatments, a pre-treatment with collagenase liposomes to reduce the extracellular matrix, and then a second treatment with a drug. In this case, we used a nanoparticle paclitaxel drug. Maybe today we'd use gemcitabine in order to treat the pancreatic tumors. And we saw that when we gave these two treatments, first treatment to reduce the collagen, and the second treatment to allow the drug to penetrate, and the second treatment with a drug, we actually had better therapeutic outcome. But here we actually had a twist in the story. So this paper was published, but before publishing it, the reviewers actually asked us to improve one of our images that we had in the paper. And this was an MRI image of the mice. And we had male mice, and we said, let's add, the reviewer asked only for one image, but let's actually add a bit more, and let's do a male mice and female mice for this image. And then we actually had a very strange result. So when the mice came back, we imaged them. These were liposomes that were loaded with gadolinium. And instead of biodistribution to the site of the tumor, we actually saw the nanoparticles distributing to this region, which I initially thought was the bladder. But luckily, the students working on this, they said, no, this is not the bladder. This is actually the bladder. This is not the bladder. This looks like the reproductive tract of these mice. And the story behind it is these are female mice. And in the animal house, an error was made, and the bedding from the male mice was switched with the bedding of the female mice. When the female mice are exposed to the male bedding or the scent of males, actually this triggers a menstrual cycle in the female mice. Unlike humans, which we have a timed cycle, in female mice, the presence of a male in their environment actually triggers the menstrual cycle. What happened is that the presence of the male bedding induced a menstrual cycle in the female mice, and this shifted the biodistribution of the nanoparticles from the tumor towards the ovaries. And I'll show the data behind. So this study was actually led by Asaf Zinger, who's now faculty here at Technion, and Maria Polai, another PhD student that we have in the lab, very talented PhD student. And what they looked at is, does sex or gender actually play a role in how we dose nanoparticles in nanotechnology? And we know that for many medications, for many small molecule medications, there's a great difference in the way they act in men and in males and females. Would the same also, and this is due to different metabolic pathways, etc., would the same also apply to nanotechnology medications? And the main evidence they saw is that when they looked at this, Maria and Asaf, when they looked at the different stages of the menstrual cycle, they saw that at the peak of the menstrual cycle, called the estrous stage, you can notice the accumulation of the nanoparticles inside the ovaries and the uterus of the mice. Really significantly, several orders greater than several fold greater than at the baseline of the menstrual cycle. More just to prove the accumulation of the nanoparticles, these are nanoparticles that were fluorescent. What we did is we took lipid nanoparticles with a messenger RNA that encodes for luciferase, and we injected it at the peak of the menstrual cycle. And you can notice that the nanoparticles injected intravenously accumulate in the ovaries and the uterus and actually encode for luciferase inside the in the reproductive tract of the mice. So we actually see a shift of the nanoparticles towards the reproductive tract, and this of course can have implications. The reason for that is that during the peak of ovulation, in order to support the potential of life, many blood vessels, so rapid angiogenesis occurs around the ovaries, and this allows the nanoparticles to extravasate out of these angiogenetic blood vessels, and the nanoparticles can enter into the ovaries. So at the peak of ovulation, we actually see about 4 times more angiogenesis inside the ovary. And we asked ourselves, could we actually leverage this accumulation in order to improve the treatment of diseases? And we chose two diseases. One is ovarian cancer, where we want to increase the amount of medicine inside the ovaries and by that actually inject at the peak of ovulation. And we saw some improvement in the treatment. So when we treated ovarian cancer, this is a very aggressive model. When we treated at the peak of ovulation, we actually saw more drug reaching the tumor site and improved the therapeutic outcome. Contrarily, when we treated breast cancer, so in breast cancer, we actually saw a different shift. When we treated at the peak of ovulation, we lost a lot of the nanoparticles that were going towards the tumor. We found them in the reproductive tract. And we actually saw there a decrease in the therapeutic effect. So here the nanoparticles, instead of going to the tumor, when we injected them at the peak of ovulation, they actually went towards the reproductive tract rather than the mammary tissue. And just to show this, to emphasize, you can see here a mouse. This was done together with Rafael de Torres de Martinez de Rosales. You can see here a mouse that has both accumulation in a breast cancer tumor. This is the breast cancer tumor. I hope you can see my cursor, and the ovaries. And this, of course, is not something that you want. So actually, the dual accumulation also in the reproductive tract, when there's no disease there, may not be in favor of the treatment that we're aiming to develop. So I'll jump over the next couple of slides and just end with a quick story, if that's okay, Marilyn?
Yes, sure.
Okay, thank you. So I'll just end with a quick story. So one, I think that what we learned is that when we come to treat men and women, I think with nanotechnology, we also want to think about how we design them in the best manner, the nanoparticles. And it's something that I learned over the past couple of years is that in addition to the recruitment of blood vessels into the tumor, actually tumors also recruit neurons into the tumor site. And these neurons support the growth of the tumor. And we asked ourselves is, could we use nanotechnology in order to target this crosstalk between the neurons and the cancer cells? And this study was led by Maya Kaduri. I didn't show work from Hanan because I knew she's showing her work previously. So this work was done by Maya Kaduri, and again this crosstalk between cancer and neurons, and just appeared in Science Advances just a couple months ago. So to demonstrate this crosstalk, you can see these are PC12 cells. So these are neuron-like cells. And this is when these cells are not activated. And you can notice that they're small and there are no dendrites coming out on the left-hand side of your screen. And when you add differentiation media, meaning nerve growth factor and other factors to these neurons, actually they start growing in size and sending out dendrites from these cells. If you take the same deactivated cells on the left-hand side and you add to them cancer cells, you get exactly the same phenomena as you get with the cells that are treated with the differentiation media, meaning that the cancer cells themselves send out signals, cytokines, that stimulate the growth of neurons, sending out their dendrites and axons towards the cancer cells. Now, this supportive environment, different factors that we looked at, but just to exemplify this in front of you, so you can see here, you'll be able to see two live movies. On the left-hand side, they're breast cancer cells on the top and neurons on the bottom. On the right-hand side, only neurons. And when we start co-culturing the top one, you'll notice that the neurons on the left-hand side will start sending out dendrites towards the cancer cells. So in the beginning, everything is quiet. The distance is still great. But then you can actually start seeing these dendrites actually being extended out towards the cancer cells. And notice how much more prominent this is on the left-hand side compared to the right-hand side. So actually, this is the black outliners of these dendrites being sent out towards the cancer cell. And so there's actually a crosstalk, and this crosstalk supports in both ways. The neurons actually support cancer cell proliferation, metastasis, and also the ability of the cancer cells to resist starvation conditions. So the neurons make the cancer cells more resistant, but the cancer cells actually recruit the neurons into the tumor itself. So it's very similar to the growth of blood vessels that we have. So this is a target. And to show it, these are the neurons inside a tumor. Two more slides and I'm finished. So I apologize. These are the neurons inside a breast cancer tumor. And when we ask ourselves, will the nanoparticles even reach the site of the neurons? What we saw is that if we have here different cuts of the tumor, but in this one, I think it's very clear. You can notice the liposomes here are in red and the neurons are in green, and the close proximity between the two. And the drug we chose to deliver in order to interfere between the neurons and the cancer cells was bupivacaine. Bupivacaine is a local analgesic. It retards the neurons. And when we used the bupivacaine to treat the cancer, so the primary tumor actually retarded in size. But more interestingly is the sites of metastasis. Actually, we saw decreased metastasis when we treat with a local analgesic that's delivered through nanoparticles. So I'd like to end here and thank you for the opportunity to speak here today to you. At first, what I showed is really that nanotechnology is there. I mean, we all know that, and I think we can be very proud of our field for delivering so many therapeutics in also a short period of time. Then I showed the osteoarthritis example of liposomes and biomaterials for treating osteoarthritis. The barcoded nanoparticles for predicting which treatment to give. Gender, I think, sex plays an important role when we come to design nanotechnology, and that neurons are interesting targets, I think, to look at when we come to treat using nanotechnology. So thank you so much, Marilyn. Thank you for this opportunity. Thank you for everyone here being on this call.
Thank you so much, Avi. Great talk, very fascinating data. For the audience, please write your questions in chat. We already have one question from Costas, and he's asking he's asking a couple of questions. The first question is, what is the vision for the clinical translation of barcoded nanoparticles?
Yeah, so the way I see it is that the clinical translation will be for predicting in breast cancer, especially in triple negative breast cancer, which is doesn't have good biological targets, to go and predict there which small molecule drug, possibly even a chemotherapy, will be the best for treating the patient. So choosing 7 medications, that's what the number that we reached. Those are the ones that are on the shelf that usually the clinician needs to choose from. And many times the clinicians actually miss, not because they want to miss, but because it's just hard to make that choice. So loading those 7 medications into the liposomes and then predicting which medication will be best for each patient. I'll say that this technology also took a twist. people have been using the barcoding a lot now to predict how lipid nanoparticles reach different sites of the body, because it's really easy to take a biopsy and then do real-time PCR in order to see where your particles are inside the body. So it's just a twist that happened over the past couple of years.
Well, there is a second and third question from Costas. Costas, I think that's enough because we need to allow other people to ask questions as well. So the second question is on the crosstalk between the brain cancer cells and neurons. So the last data you show, what about brain cancer?
Yeah, so great question. So one, thank you, Costas, for the question previously. So in brain cancer, actually, we saw something interesting. I'm saying this is very preliminary. So in pancreatic cancer, we saw strong crosstalk between the two. In breast cancer, we saw strong crosstalk. In other types, actually in brain cancer, we weren't able to define what type of crosstalk we have there. So I'm not sure about brain cancer, what type of crosstalk exists there. I'm sure there is some type, but it seems that it differs from what we see in pancreatic cancer or breast cancer, for example.
And then the third question that is coming from Costas is if the barcoded liposomes will be used as a companion?
Yes. Yeah, that's one of the goals. So a companion diagnostic for predicting ahead of time, will this drug be the right drug? Let's say you have today a liposomal drug, you can use this as a companion diagnostic. So a companion diagnostics makes a lot of sense, yes.
Great, thank you. Kelly is asking a more general liposomal formulation question. So how do you select the different types of drugs that are used in these drug cocktails that you've shown to be safely delivered together?
Yeah, so we deliver in the barcoding system we use is at diagnostic levels of the drug, so very low, about 1/1000th of the therapeutic dose. And what we did is we actually we went to the clinicians and we asked many breast cancer clinicians which medicines they give for treating triple-negative breast cancer. And they gave us lists, and we verified those lists, and then we narrowed it down to 7 medications that are considered to be potent, but that there are a lot of errors there, meaning that about 30% of patients don't respond. So those were the medicines that we chose.
Thank you, Avi. We have one question about the tissue biopsies. So Anita is asking if you find any differences in the response of the drug if you take tumor biopsies from different areas of the tumor. So the tumor core or the marginal area.
Yeah, absolutely. So I think one thing, so I think clearest when we looked at the primary tumor and the metastasis, but there's a beautiful paper, I think in Cell from several years ago that shows how different biopsies from different locations actually respond to different medications. And I think one of the advantages of using nanotechnology is that, it distributes to many regions in the tumor, and you can actually, the more tissue you get, the better the analysis. So, and one of the nice things really with using nanomedicine is that you get very good coverage of the tumor. Areas that are necrotic, dead already, so those we probably won't get good biodistribution, but also the readout there isn't good. But you can actually take, the more tissue you get, the better.
Great, thank you. If you have any other questions from the audience, please write them in the chat. I have a question as well, Avi. So we know that Doxil is administered in advanced ovarian carcinoma patients. Do your data suggest that we need to be careful of the day of administration based on the ovulation?
Yeah, so thank you for that. I think so for some patients that have ovarian cancer, they already don't have they don't have their menstrual cycle, and for others, sometimes they're given actually medications to stop the menstrual cycle. I think more and more data is coming out to show that the timing of treating with the drugs, including nanotechnology drugs, the timing of the month will play a role in the therapeutic efficacy. And I think we should, especially, for example, for young mothers. If there's a young mother that's treating a disease, and now the nanoparticles, I didn't show it here, but this will be coming out in ACS Nano in a couple of weeks. that we see increased toxicity in the ovaries if we inject at the peak of ovulation. And of course, that's important. For example, if the patient with breast cancer and she's young and she wants to preserve her fertility, we want to make sure that we're not harming the ovaries and the uterus with the accumulation of the drug.
That's very interesting. We have one more question from ICN2 and Nirea. So she's asking if it's safe to use a drug cocktail in terms of cell death. So she's wondering if the amount of healthy cells that are dying as a response is higher if you're using a drug cocktail. But I assume the answer there is those, right?
Yeah, so I think there's the question is, for example, are we creating resistance inside the tumor? I don't think so, because the amount per particle is enough to kill a cell if that cell is responsive. So we have just in a Doxil particle, we have between 10,000 to 20,000 molecules of doxorubicin in each liposome. And when that reaches a cell, that's more than enough to kill a cell. And the same is also true for the other medications. So if the cell is not responsive to that specific medicine, then you won't see any activity. And because we give it at a diagnostic dose, the goal really is to then give a readout and then treat with the full amount of the drug, of the best drug.
Okay, thank you. So if we don't have any other questions, I guess we need to thank one more time Avi for being here with us. Thank you very much for the amazing talk. And you will receive updates from me for the follow-up seminar.
Thank you so much. I appreciate this very much, this opportunity. And thank you, everyone. Shalom from Israel.
Bye-bye, everyone.
Bye, shalom.